Dear all, welcome to this Saturday evening, and we would like to present Foxy Infertility Committee presents a fertility management of PCOS with educational grant bond by Sanofi. So, at the first, I would like to thank the Foxy President, Dr. Alpesh Gandhi, Secretary General, Dr. Jaideep Tank, and Vice President, Dr. Ramani Devi, for allowing us the proceedings for the same. We have a galaxy of stars today. So let me first introduce Dr. Kundan Ingale, who is the Chairperson for Infertility Committee Foxy 2020-23. He is the Founder Treasurer Maharashtra Chapter, and then he's the Director Nirmati Clinic Center for Assisted Reproduction and Endoscopy in Pune. He's received several awards: second best research paper in ESAR, third best research paper in AICOG, and first best research paper in ESAR 2019. Welcome, Dr. Kundan.
Thank you, Session.
Sir, may I request you to kindly go ahead and...
Thank you, Session. Yeah, okay. So, good evening, everybody. I thank you, Dr. Bharti Dore Patil, Madam, and Dr. Kavita Gautam to join us during this session. And at the outset, I want to thank Science Integra for organizing such an event on this particular focus topic. And today, we are going to discuss on fertility management of PCOS. So, friends, PCOS may be defined as a syndrome of hyperandrogenism and anovulation in the absence of other hypothalamic, pituitary, ovarian, or adrenal disease. This is a kind of a very old definition of PCOS, which covers its pathophysiology as well as the origin of the defect. Now, this was a classification in the past we used to follow, major criteria and minor criteria. Now, we follow this Rotterdam criteria, which was invented and by a consensus meeting, and it clearly says that at least any of the two following criteria should be fulfilled. One is the polycystic ovaries, that is the sonographic finding. There has to be a history of oligoanovulation, that is anovulatory cycles. And third, there has to be a clinical or biochemical evidence of hyperandrogenism. So, any of these two of these three criteria, if they are present, we can say the patient has a polycystic ovarian syndrome. Now, coming to the important part of the PCOS, which is a insulin resistance, and we must, I'm sorry, I'm getting some disturbances, but can you hear me very clearly?
Yes, you can. We can hear you.
So, there are clinical and biochemical findings which are suggesting of insulin resistance. So, we have to look for these kind of signs and also some symptoms so that we can probably think that this patient, does she have any insulin resistance or no? So, one of the very important tests, which is a 2-hour 75-gram GTT test, where if the fasting blood sugars are more than 100 and 2-hour post-glucose consumption sugars are more than 140, we can say that this patient do have a insulin resistance. But at the same time, we also look for certain clinical findings like presence of acanthosis nigricans, one of the very important marker of insulin resistance, and also some subcapillary skin fold with increased waist to hip ratio. And into certain biochemical findings which are supportive to your other, the GTT test, which is a fasting insulin level, or we can go for a fasting glucose to insulin ratio and history of amenorrhea. So these can be the supportive signs which we can take a help to confirm that does she have an insulin resistance. Now, friends, we know that the insulin resistance is almost there in almost all PCO patients, but very clearly clinically evident into 65 to 70% of the women. And out of those, at least those who are having BMI more than 30, that is obese PCO patients, we have almost 80% patients going to have an insulin resistance. And it's not absent in thin limp in PCO patient. It is definitely there, but little number of percentage is 25% around in those bearing this kind of. So PCO syndrome or a PCOS, it's a combination where patient suffers with infertility, hirsutism, menstrual disturbance. She also has obesity, but we must understand the biggest reason behind or etiological factor for PCOS is an inheritance of insulin resistance, and that is very, very important. We have to keep it in mind. So these are the clinical features with which patient comes to us, PCOS patient comes to us in a different age groups and with a different types of symptoms. So we can have patients who are presenting to us, which is most common presentation, which is menstrual abnormality, that is irregular or anovulatory cycles. Especially, it's a classical sign where we look for PCOS when a young PCOS, adolescent PCOS girl presents to our OPD. Now, sometimes patients present to you with a reproductive abnormalities, like she's not able to conceive. So infertility is also one of the common presentation. So when we look into, these are the two categories patients who will visit to us, and then we look for, say, polycystic ovaries on pelvic sonography or transvaginal scan, or signs of hyperandrogenism. Sometimes they do have a psychological features. You specifically ask a leading questions and you can elicit that she does have a psychological disturbances, and after the investigation we get to know that she does have a metabolic abnormality. So that these are the clinical features of PCOS. Now, once we confirm say PCOS diagnosis, which investigation will like to do? Especially, are we ready to advise her for all the androgenic features? So not really. So after transvaginal ultrasound, we can ask for a day 2 FSH and LH and see the ratio. We can ask for a free testosterone level and sex hormone binding globulin. I think these are the few very important investigation to know the pathophysiology and the current status of polycystic ovarian syndrome. Now, coming to our main important topic today, which is fertility management. So friends, I'm going to give you certain evidence which are in a very recent years and which are going to help us to understand about a lot of controversial factors of management of PCOS. So most important, we need to understand when we discuss about insulin resistance in a PCO patient as a main etiological factors, this particular strategy of lifestyle modification comes into first priority. Now, this includes exactly a weight reduction, but this includes a combination of a calorie restriction. We have to increase the physical activity and we have to modify the behavior. So what do you mean by weight loss in PCOS? So it has been very clearly shown that if a patient having probably obesity or overweight, but if they reduce 10% of the weight, I think they do show a significant improvement in metabolic and reproductive function, which is actually help us to achieve a reproductive outcome very easily. So we may not need a correct BMI achievement, but we just need a 10% weight loss can also help us to optimize our success rate. Now, it works better if we achieved it in 6 months, because prolonged weight loss probably will not help us so quickly. But if we ask her to lose the weight in 3 to 6 months, it's going to change her hormonal milieu in her body, which is abnormal, so that it gets corrected and we get a success as early as possible. I think the loss of abdominal fat is the most important predictor of the weight loss. So I think waist hip ratio does help to follow up these patients. Weight loss increases sex hormone binding globulin concentration, and that is why it reduces the free androgen levels in these patients. And somewhere we have to have a target of energy deficit of 30%, or if we talk in dietitian language, it is 500 to 750 kilocalories per day. Because if this kind of restriction, if we ask patient to do, then at least with the help of only dietary restriction, she will be able to achieve 1 pound loss per week. And especially diets should be restricted in a carbohydrates, which are a bigger bulk in our Asian diet, and it typically really provides you a very rapid initial weight loss. And I think that's a very important principle in a diet advice to the PCO patients. Now, as we know, it's very difficult to follow the diet. So what I always feel, and I always tell my patients, that we just follow diet over the time period. Probably don't concentrate on the 100% following the diet chart, but just adhere to the diet chart, so that 70-80%, so that you are still able to achieve a significant weight loss. Now, high quality diet at the same time, because we are restricting her with a certain dietary items. So those especially fruits, vegetables, whole grains, lean poultry and fish should be encouraged to provide that overall health doesn't get affected. Now, in lifestyle modification, there is a lot of evidence which we'll discuss in the future slide, that if we administer some certain types of drug like appetite suppressants like phentermine or sibutramine, especially sibutramine, or absorption inhibitors like orlistat, which are available with us. If we combine with the diet restriction with these kind of medicines, we definitely helps patient to have that kind of targeted energy restrictions. Or sometimes we do have a patient who is morbidly obese, so doing a bariatric surgery is very, very helpful in such a group of patients to achieve significant weight loss in a shortest time. So it's a very good strategy. Now, this is the evidence in 2015 published in Journal of Clinical Endocrinological and Metabolism, where a group of patients, it's a randomized control trial. All PCO patients were divided into 3 groups. One group received only oral contraceptive pills. Second group received a lifestyle modification, and third group received both combined, oral contraceptive pills plus lifestyle modification. Now, in this particular group of patients, there was a calorie restriction, there was a weight loss medication, and also increased physical activity, and the target was to reduce 7% weight loss. Now, let's look at the results. So, cumulative ovulation rate, if you look into the second and the third column, where in lifestyle only group, they could achieve 60% of cumulative ovulation rate in this group of patients. And when it was combined with oral contraceptive pills, it was 67%. Though it was not significantly different between lifestyle and combined approach, but it was significantly, statistically significant when lifestyle was compared with oral contraceptive pills. So I think it was one of the very important strategy. Also, if we look at the live birth rate, 12% with 26%, which is very, very significant in favor of lifestyle modification. And I think these kind of interventions, they eliminate the adverse metabolic oral contraceptive effect, and compared with oral contraceptive effect, pre-treatment leads to higher ovulation rate. And I think that is why it is one of the very important part and the first step towards the fertility management. Second step, which is a role of insulin sensitizers. Again, quite a lot of controversial papers over the last 2 decades which are coming, and sometimes we think that it is good, sometimes then few years later we think that it's not improving live birth rate, we reduce their consumption. Now again it has started a lot of papers coming that it is useful. So I think what is the present evidence which we have till today? So important drug, which is first drug, is a metformin. So this was a kind of a Cochrane's database review, where in 2007 48 studies were included, 4,451 patients were included, and out of these 48 studies, 42 studies were actually studying metformin as a drug for insulin sensitizers. Now they concluded that metformin alone may be beneficial over placebo for live birth, but this was a low quality evidence according to 2012 review. When metformin was compared with clomiphene, live birth rate inconclusive due to lack of evidence and differed by BMI. So I think this was very important point, because after 2012, when it was concluded that it doesn't improve live birth rate, but at the same time, the same group, that is Cochrane review, says that there is a definitely lack of evidence, and we do see live birth rate differing according to the different body mass index. So I think we cannot add surely that can improve birth rate. Now we know that clomiphene versus clomiphene along with metformin combination, that is definitely has proven that it improves pregnancy and ovulation rate after using a metformin along with clomiphene. What about metformin alone or combined with clomiphene? So there is no evidence of increased miscarriage with this kind of drugs, and metformin is associated with higher GI side effects. So these are the current 2017 interpretations of all the studies of randomized control trials who studied. So even ASRM in same year, they gave some guidelines regarding a metformin using PCOS patient, and according to them, there is a good evidence that metformin alone versus placebo increases the ovulation rate in women with PCOS. But if we combine that metformin along with clomiphene, it improves ovulation and clinical pregnancy rate significantly. And there is a fair evidence that ideally we should give metformin for at least 2 to 3 months, and then followed by ovulation induction with the oral ovulagens, then that will improve the live birth rate significantly. So it's a good practice to give insulin sensitizers first, wait for 2 or 3 months, and then start doing ovulation induction, rather than starting metformin and ovulation induction at the same time. The evidence is more favor of pre-treatment first. Now, as we understand in the initial slide that lean thin PCO patients do have 25 to 30%. So this was a study which was done in 2005, which was quite old, but this was one of the few studies which was specifically done for metformin in a lean woman of PCOS. So here 17 patients, it's a very small size study, but it was a randomized trial. So 17 patients who had BMI less than 25, 17 other second group patients who had a BMI more than 30. Now all these patients were given metformin, and this study concluded that the menstrual cyclicity, that is regularity, was 100% in lean women PCO patients when metformin was given to them for at least 12 weeks in 500 milligram 3 times a day. So while giving this therapy, they were monitored for natural ovulation by sonography, and it was 100% in lean PCO patient. But in fact, in obese women, it was only, the ovulation was restored only in 41%. So in fact, this study highlighted that probably ovulation rate is much better with metformin in a PCO patients, or probably because they are lean patients, so they don't have a very severe insulin resistance, and that is why they respond to metformin quite quickly, and they do also show a higher pregnancy rate of 64.7% in lean patients versus 17 to 18% in obese women. So lean PCOS women have a subtle degrees of insulin resistance that respond to insulin sensitizers by reducing androgen production and thereby improving ovulation and pregnancy rate, was the conclusion of this 2005. So what about the second insulin sensitizers, which is a myoinositol? Now we know that it's a nutritional supplement. So this was a German observational study in 2016 where they wanted to study whether it is a safe and alternative approach in PCOS women. So 3,602 infertility women with PCOS, they were administered with myoinositol along with folic acid for 2 to 3 months in a dosage of 2 gram per day myoinositol and 200 microgram of folic acid, and this was given for 2 months, and 70% of these women had restored ovulation. And not only that, even if you look into the chart, the total testosterone, that it was before treatment, it was 96 nanogram, but after the treatment of myoinositol, it significantly reduced to 43%. And even if our most important parameter, which is free testosterone, showed a significant decrease in the levels, that is from 1.2 pre-treatment to 0.35, which was again a significant level. So I think in even this particular group patients who received myoinositol for 2 to 3 months, they did show that 15% of the patient also had a spontaneous conception. So this was another very good evidence that because about myoinositol, we don't have a good number of studies. There are very limited and very selected countries, selected population studies are existing. So this was a review in 2018 about effectiveness of myoinositol in PCOS. This was a meta-analysis and systematic review. Till 2018, they found 10 trials which are randomized control trials, and they included 573 patients, and they concluded that if we give myoinositol, it does help to improve HOMA index and also increase the estrogen levels in these patients. But there is no strong evidence that myoinositol per se has an effect on the total testosterone levels. So this was a conclusion with this meta-analysis in 2018. Then, so we wanted to know whether should we give metformin or should we give myoinositol, which is better. So this was another comparative trials between these two drugs. Again, this was randomized control trial in 2017, but very small size patients, 25 patients in each group. One received metformin, one received myoinositol. So they found that insulin secretion, body mass index, menstrual cycle length, acne and hirsutism at baseline and after 6 months of therapy in both groups were absolutely similar. But there was little difference into certain parameters, like insulin sensitivity improved by both the treatment groups. So the main purpose of insulin sensitizers to improve the insulin sensitivity has been proven by both the drugs. The body mass index was significantly decreased in both types of patients. The menstrual cycle was normalized completely in 50% of the women with both drugs, but they did not found a significant change in acne and hirsutism with both of the drugs. Again, we just cannot take this evidence as a pinch of salt because it's a very small size study and we're really looking for a more number of patients. And then 2019, we had this meta-analysis where till now 6 randomized control trials who compared metformin with minoxidil with 355 patients from these trials, and they found that there was no difference between metformin and minoxidil in improving fasting insulin or those parameters of insulin resistance like HOMA index and testosterone, SHBG levels and BMI. So there was a strong evidence by this review of increased risk of adverse event among women receiving metformin compared to those receiving minoxidil. We know that metformin and its GI side effects are something which actually on the negative side of metformin, which we have advantage with minoxidil. Now, the use of inositol isomers, that was another controversial point, and this was a comprehensive review in 2018. And they say that especially in ovary, the concentration of minoxidil to DCI, that is dichloroinositol, exists in the ratio of 40:1. And if we supplement them in this kind of ratio, it does shows improvement into metabolic, hormonal and reproductive aspects of PCOS. And also it has been shown that it does improve the clinical outcomes of ART treatments when it is advised to such women. Now, there is another third part of insulin resistance, which is a controversial, that can we combine these two drugs and can they be very helpful to achieve effective synergistic insulin resistance effect in reducing insulin resistance effect. So we know that metformin acts at the little central level, that is at liver level, where it increases it decreases gluconeogenesis and decreases lipid synthesis, and myoinositol, it increases the glucose uptake by the muscles and it decreases the lipolysis, which ultimately both the drugs in a different way reduces the insulin resistance. So I looked into a lot of literature for this combination if we use it, and I found only one randomized control trial till now, which is again unfortunately this trial is not followed up for clinical pregnancy rate and ongoing pregnancy rate, but they followed the pregnancies for live birth rate. Again, it's a good parameter to follow up, but let's see what evidence this trial has got for us. So 120 infertility PCOS patients, they are randomized. 60 patients received a combination of metformin with minoxidil, and another 60 patients received only metformin. Now the primary outcome was live birth rate. So after giving this combination to these patients, they followed up for 3 months for a ovulation, which was spontaneous. Then at the end of 3 months, if those patients who did not ovulated or did not conceive, then they were induced, for the ovulation by clomiphene. And then secondary outcomes were also noted, that is improvement in menstrual cycle, whether there is any correction into hormonal and biochemical parameters, about spontaneous conceptions, abortions, multiple pregnancy and OHSs. And out of this, the group which received combination, they noted that there is a significant improvement into menstrual cycles in group 1 patient who received metformin and minoxidil. Not only that, they reported that those patients who got pregnant after this kind of combination, the live birth rate was 55% with the combination versus 26% in a group who received only metformin. So significant higher live birth rate received in combination of metformin and minoxidil. So probably we're still looking for these kind of studies, that are they going to really, this combination is going to help us to achieve more and more. I mean, using these two drugs are synergistic to achieve the result, or using only one single dose should be enough, or single drug should be enough to achieve the same goal of reducing insulin resistance and at the same time pregnancy. Now, let's go step ahead, that we have worked out our patients for PCOS for the management, where we have already done a weight loss. We have given them a sufficient time insulin sensitizers. Now coming to the treatment of ovulation induction. So this particular trial of using oral contraceptive pills just 1 or 2 cycles prior to ovulation induction has concluded that if we give oral contraceptive pills at least 1 cycle or 2 cycles prior to ovulation induction, it significantly has a higher percentage of patients who also ovulated and also having a pregnancy. So because it does help us to downregulate pituitary. Coming to the now ovulation induction drugs. So we have 2 important oral drugs, which is clomiphene citrate versus letrozole. And we know that clomiphene citrate has got a couple of kind of side effects, which are on the cervical mucus as well as on the endometrium. But most important, when clomiphene was combined with, compared with letrozole, the ovarian hyperstimulation rate is significantly low with letrozole, which is almost 0%. And I think it matters for us in especially ovulation induction treatment of PCOS, and I think that is why nowadays letrozole becomes a first choice, and rather than offering a clomiphene still today, this is what I follow in my practice. Now it has been shown that when we discuss about optimization, because our goal of ovulation induction is to achieve a pregnancy in the shortest time, and that is why our each month, each ovulation induction cycle, we need to optimize our success rate. And here this study clearly says that if we combine letrozole along with human menopausal gonadotropins of 75 IU, we have a significant higher pregnancy rate of almost 55 to 70%, that is cumulative pregnancy rate. And I think we have a better endometrial thickness, we have a better number of mature follicles, and they are higher in the letrozole and the HMG group. So instead of using just letrozole, I still prefer putting the patients letrozole followed by HMG, and that is something which we follow today in majority of the ovulation induction cycles. Again, this one study which I skipped it, which was again proven that letrozole is better in comparison with giving clomiphene along with metformin. And even the systematic review in 2017 about treatment strategies for WHO group 2, that is PCOS and ovulation, they say that letrozole is the only treatment showing a significantly higher rate of live birth rate. Now, just to revise ourselves, brush up, how we can do a different ovulation induction protocols. So we can give from 2nd day to 6th day, 5 days letrozole of 5 milligram per day, because it is associated with better pregnancy rate than even 2.5 letrozole. So 5 milligram per day from day 2 to day 6, and follow up the follicular monitoring. And once the follicle is 18, give SCG, and maybe at the end of 40-44 hours, you do a single IUI, supplement them with progesterone, and then 17 days later, you can do a urine pregnancy test. Typically in this protocol, we get a single dominant follicle. Now there is a low dose FSH in a down-regulated cycle protocol. It was proposed to achieve a single follicular growth, because we down-regulate pituitary first by giving GnRH agonist 0.5 milligram daily. We give it for 11 days. Once patient gets some period, from 2nd day, we start very low dose of recombinant FSH, either 37.5 to 50 IU for 7 days. And after 7 days, we review it with the sonography, and then we decide whether to increase or continue the same dose of FSH, and rest of the management is same. Now here in this protocol, generally most of the cases we get single follicular growth, but it's too long duration treatment, multiple injection, frustrate sometimes to our patients, even if they don't get pregnancy in couple of cycles. Now this was another protocol which, according to the 2017 review, that we give 1 cycle of oral contraceptive pills, followed by, once she gets a period, we give letrozole 5 milligram for 5 days from day 2 to day 6. From day 7, we add HMG. We can add 75 IU or 150 IU daily till the SCG. So it's a daily injectable rather than alternate day. You'll have a better follicular growth. And then once the follicle is 18, then we can give SCG. Typically, if we combine this protocol, then we typically get 1 or 2 dominant follicles on the day of SCG, and the next management is quite same. Now, we can have a better number of pregnancy rate or better ongoing pregnancy rate if we introduce gonadotropins by little early in the cycle, that is on the 4th day. So this protocol where we give letrozole on the 2nd and 3rd day only, that is 5 milligram per day, and from 4th day onwards we introduce HMG 75 IU daily till follicle gets 18 millimeter, and then we give SCG. Typically, if you introduce gonadotropins early, there are 2 or 3, in fact sometimes 3 or 4 dominant follicles by the day of SCG, and that is why in these protocols there is a higher percentage of premature LH surge. So sometimes it is good idea to check the LH levels once the follicles are 14, and if it is more than 5 and less than 10, then for those next 2 days give GnRH antagonist if LH is more than 5 and less than 10 to save the cycle from failing due to premature LH surge. Typically, we can, in our study, we found 27% clinical pregnancy rate and almost in the range of 20% ongoing pregnancy rate with these kind of protocols in last over 3 to 4 years. Now, a meta-analysis says that if we use GnRH antagonist in a patient who is undergoing controlled ovarian hyperstimulation with IUI, then there is a significant increase in the clinical pregnancy rate. There is a significant decrease in the premature luteinization rate, and this is meta-analysis in 2014. Now, this meta-analysis does point out that this effect, especially by GnRH antagonists, they found it more significantly in a non-PCOS patient, but less in the PCOS patient. But I think when I went into detail about this meta-analysis, then I realized that this meta-analysis drawn this conclusion that it is not significant in PCO patient. So it was only 2 randomized control trials was involved, and they were also very small studies. So in fact, same meta-analysis says that results pertaining to PCO patients should be interpreted with cautions, and we need more RCTs to say that it is not effective. So I think still the evidence says that it is effective whenever we don't recommend to use GnRH antagonist for all PCO patients when they are undergoing ovulation induction, but especially when you are using a gonadotropin cycle, I think it is definitely recommended, because incidence of premature LS surge is in the range of 25 to 27% when you are using gonadotropins. So I think it's going to be a very effective strategy in these patients for optimization. Now, this was a retrospective cohort study about GnRH antagonist in IUI cycle, where slightly more number of patients were involved. They were randomized into, it was a retrospective, so they were divided into 2 groups, 88 PCO patients who received antagonists as soon as the follicle were 14, and 87 patients received only gonadotropins without antagonist. And they demonstrated that the combination, when antagonist was used, the peak LH level on the SCG was absolutely under control, but in case of recombinant deficits without antagonist, it was significantly higher. Not only that, they noted that the established LH surge that has happened only 7% when antagonist was used, and when it was not used, it was almost in the range of 27 to 28%, which is quite high. And clinical pregnancy also, though it was not significantly different, but at least 6% was higher when antagonist was used. And I think all of us, we will understand that when we have IUI treatment success rate going from 12 to 18%, for us it is going to be very effective strategy. Though it is not clinically significant, but 6% is quite good in terms of IUI treatment. Now, few slides about comments about gonadotropins. So this was a randomized clinical trial when it was compared. The human menopausal gonadotropins was compared with clomiphene citrate. So here, patient directly started with low dose HMG of 37.5 to 75 IU per day, and another group received clomiphene citrate 50 milligram per day from day 3 to day 7. And look at the clinical pregnancy rate and live birth rate was significantly in favor of HMG. Even the endometrial thickness was significantly better with HMG than clomiphene. And the most important parameters, look at the cancellation rate, significantly low, that just 5% in low dose HMG versus 15 to 16% in clomiphene citrate. I think that is why even pure gonadotropin cycles is very, very effective. So we can decide our protocol as per our convenience. Now, this is the protocol what we can do, that we can start off either recombinant FSH in the range of 37.5 to 75 or HMG 75 IU right from second day, give it for 4 days. 5th day you call up patient for a scan. If the follicles are, the selected follicles are not more than 10, you can step up the dose, that is 10 millimeter. But if you have a 11-12 millimeter follicle, no need to step up, continue the gonadotropins. But definitely if you have more than 2 or 3 dominant follicles, take a help of antagonist to reduce the premature LH surge, and you can easily achieve 27 to 30% pregnancy rate in these group of patients. What about vitamin D supplementation in PCOS patient? So this was a 2018 review. We know that the review and meta-analysis, they always include randomized control trials, and this meta-analysis does conclude that supplementation of PCOS patients with continuous low doses of vitamin D, that is less than 4,000 IU per day, or supplementation with vitamin D as a co-supplement, it helped to improve insulin sensitivity in terms of fasting glucose concentration and the HOMA insulin resistance index. So it was found that the HOMA index was declined significantly when vitamin D was supplemented with a dose lower than 4000 IU per day. So I think this was another good evidence that in few number of patients who are classical insulin resistance, even supplementing them with a vitamin D is quite an effective strategy. What is your opinion for ovarian drilling? That's a question, because we know that ovarian drilling is no more a first line drug, first line treatment. It is always a second line treatment if our ovulation induction fails, because we know that with ovarian drilling we have a fewer live birth rate. Not only that, but also we have a significant decrease in ovarian reserve if we do little with courageously and over enthusiastically drilling. And also there is an increased incidence of ovarian adhesions after the laparoscopic drilling, but it does have a little significant effect of reducing the multiple pregnancies. So I think it is reserved for certain number of selected patients, cannot be a generalized treatment. Can we advise IVF per se in a PCO patients? So there are specific indications where we advise IVF in a PCO patient as a first line, where it is if we look into the category wise in a descending order, IVF is offered as a third line therapy after the first and the second line ovulation induction therapies. They have failed. Then in absence of absolute indications of IVF, still we can advise our PCOS patient to undergo if our first two lines are failed. GnRH antagonist protocol is the most preferred in this PCO patients undergoing IVF for ICSI cycles over GnRH agonist protocol, because it does reduce the duration of stimulation, total gonadotropin dose, and also the incidence of ovarian hyperstimulation. But remember, ovulation trigger with GnRH agonist and then freezing all the embryos could be considered as an option in women with PCOS in those who have the increased risk of developing OHSS. But in fact, now it's a common practice that when we do IVF in PCO patients, we always like to do a frozen embryo transfer frozen embryo transfer cycle for these group of patients. So this is the protocol for IVF, where we start gonadotropins from second day, we wait for 4 days, fifth day we scan them. On fifth day, if we are following a fixed dose antagonist protocol where we introduce an GnRH antagonist here on the fifth day of stimulation, we give everyday antagonist along with gonadotropins till the follicles are 18. Or if it is flexible protocol, then we wait till the follicles are 14 millimeter by 6th or 7th day. In flexible protocol, we introduce antagonist once the follicle goes to 14 millimeter. So by using antagonists, we do a pituitary downregulation. With gonadotropins, we achieve multiple follicular growth, desired follicular numbers, and by giving GnRH agonist as a trigger, I think it will help us to reduce absolute risk of ovarian hyperstimulation. And we know that if we are using GnRH agonist, it's better to freeze all embryos, and it does help to improve the success rate. So to my colleagues, to summarize my talk, ovulation induction in PCOS needs individualization. Letrozole is the first line therapy for ovulation induction in PCOS when it comes to controlled ovarian hyperstimulation with IUI. Letrozole with HMG gives better clinical pregnancy rate than clomiphene alone or clomiphene along with metformin. And metformin as an insulin sensitizer is a very useful drug to be given along with oral ovulations to improve clinical pregnancy rate. Metformin with minoxidil combination therapy showing promising results, but we are still waiting for a significant better studies so that we can actually use this combination in our practice. Ovarian drilling is also not a first line treatment in PCOS. Better to be advised in patient whose follow-up for treatment is questionable. GnRH antagonist is helpful to prevent premature LH surge, even if it is IUR or IVF in gonadotropin cycles. So thank you friends for patient hearing, and I thank Sanofi and Science Integra for inviting me to speak on this topic, and I hand over session back to Mr. Sheshan. Thank you very much.
Thank you very much, Dr. Kundan. It was a great talk. We are having an audience in excess of 700 members now, and questions have been coming through. So let me first introduce the moderator for this session. So the moderator is Dr. Kavita Gautam. Welcome, madam. She is the South Zone Coordinator for Foxy Infertility Committee, Medical Director, Bloom IVF. She is a Senior Consultant in Reproductive Medicine and High Risk Obstetrics. She has gotten a varied amount of training across the world, and she's been awarded with a lot of awards, prestigiously the JL Javeri Award, Fellow of International Academy of Medical Sciences, and the TOG Award. Welcome, Dr. Kavita. And let me also introduce the expert for today. So we have Dr. Bharti Dore Patel from Pune. She is the Director and Chief IVF Consultant, PFC S-Smile IVF, Head of Gynecology Department in Shri Hospital, Pune, National Vice President, Foxy 2016, Past President, POGS, Past President, IMA Pune, and she has been a varied number of positions across Foxy and other associations. Welcome, Dr. Bharti. So I hand over the call to the moderator, Dr. Kavita Gautam. Thank you, ma'am.
Thank you, Session, for the introduction. I go ahead with the questions. I think, Kundan, you've given answers to many of the questions, but still there's a lot of questions being asked, and many are related to the adolescent PCOS. So I think coming to ovulation induction for PCOS and reproductive thing, I think we keep discussing about it. Adolescent PCOS is something which many have as a doubt. When you see a 15-year-old girl entering into your chamber with PCO features, that is when you think what to do and what not to do here. So many of the questions are related to that. So to start with, is it mandatory to regulate all irregular cycles? This is a quite interesting question. So Bharti ma'am, any of you can take this question. Is it need to regulate all the irregular cycles?
Madam, you have to unmute your hand. Yes.
I think Kundan can take. Kundan is a speaker.
Okay. Actually, it's not necessary that we need to regulate the adolescent woman for regular cycles, but we need to understand certain points about PCOS in adolescent girls. Preferably, if the patient is coming to you with a history of menorrhagia along with irregular menses, I think it's a very important indication to treat this group of patients. And also, majority of times, these patients do come to us with a presentation of hirsutism. I think that is why in certain group of patients, we will like to treat adolescent PCO patients. But I won't treat her for the regularization of the cycle. Another group of patients where we really think that she should get her menses, especially those adolescent girls who actually gets a period or menses after giving withdrawal only. So they have a prolonged amenorrhea and then they take progesterone for a withdrawal. So I think such group of patients we can advise that to avoid that prolonged exposure of estrogen, that every after 6 weeks they can take 5 days progesterone and have a withdrawal, and so that we reduce their duration of exposure. So I think this is the only kind of treatment we can focus when it comes to regularity of the cycle. And I think there are many ways. I think Dr. Bharti Madam will like to highlight about it.
You have to categorize the patient, especially adolescent patient who have regularly irregular cycles and irregularly irregular cycles. If the patient has got 4 months, 5 months amenorrhea for a long period of time, amenorrhea is not very good for them. So probably those category of the patients, or who has a PCO, very classical PCO, like they have a hirsutism, they have obesity. So those kind of thing, unopposed estrogen will not be a very good idea to keep for a long time for them. So those patients probably we may go ahead for the regularization. But if a patient is not very obese or patient is not classical, just irregular menses, and maybe she has a second feature that is a PCO morphology, but she doesn't have a biochemical feature. Probably those patients you can leave and they are regularly irregular, like every 2 months they are getting, 1.5 months they are getting, that's okay. Those patients you can just keep them just like that, and you just kill them, as Dr. Kundan.
I think majority of the times we have to counsel their parents that getting those 6 weeks, 8 weeks menstrual duration is not harmful. It's not going to harmful to them physically. But I think it's a very important point to counsel them that about regarding impact of this situation in her future reproduction. So I think especially when because once we explain them, because majority times than the patient, their parents are more anxious. And I think it plays a very important role, because otherwise they keep hopping on and off to the doctors from one place to another, because they feel that there was no treatment offered. So I think we have to make them understand the pathology. We have to take out those misunderstandings that getting irregular menses is not going to harm them physically. I think these are very important points in counseling the parents.
Yes, I think we should also insist on lifestyle modification.
Yes, of course.
Diet and exercise, we have to re-insist for these adolescent girls.
Yes.
That
Yes.
is when they lose everything.
Absolutely.
And is it mandatory to, when and which medicine for adolescent? What kind of treatment you start for adolescent girl? And how long will you treat?
Okay. I think, as Madam said, that we must categorize our patients. So, especially if it is a lean, thin PCO patients, I do not give them treatment, but I do once at least get a GTT done for these patients, and we assess their clinical markers, so that I want to know whether she does have a insulin resistance. Because even if it is a thin patient or an obese patient, even if it is she's in an adolescent phase, if she has an insulin resistance, I will prefer giving them metformin, because it is going to help them in a correction of many things. Not only insulin resistance, it's going to help, especially if they are overweight, reducing the weight. It's going to correct the androgen atmosphere in her, and also it helps her to come out of that insulin resistance state little on the severe disease to mild disease, which will help her to, by the time she goes into reproductive age group, she has a lesser androgenic features. So she start responding to your ovulation induction treatment much better. So that's number one. But typically, if the patient is an obese girl having PCOS and irregular menses, then apart from insulin sensitizer, she don't require after investigation. But I will insist her, and I'll make her understand that only strategy which is going to help you to go back to your really realistically natural, ovulatory cycles is weight loss. And I think we need to counsel them that how going to be the impact of reducing that weight significantly, because she has 4 or 5 years option available to go back to the targeted BMI over the years, and how she is going to avoid getting into infertility if she achieves a significant weight loss in over the time period. So I think weight loss, lifestyle modification will be one important choice, and along with insulin sensitizers. I'll be a little skeptical about oral contraceptive pills giving for a longer time. I will not do that. Even I will not prefer just satisfying parents for giving oral contraceptive pills for 3 or 6 months just to make them feel that the cycles are regular, because effectively it's not going to correct her problem. After suggestion of 6 months, after a couple of cycles, regular cycles, she's going to again have an ovulatory cycle. So realistically, OC pills do not solve their problems. I think I like to have even Madam's opinion.
Important landmark study now, which guidelines actually has come out, that adolescent period, like from menarche, we used to always think that the 5 years down the you should start regularizing their cycle and start the medication, but it has now come that 13 years you have to wait. So till then, I don't think any oral contraceptive pill has any role. Dr. Kundan said is very rightly. Now categorize your patients again. Adolescent period is from teen, it starts 13 years till it is 8 years of age. So now 13 to 16 years of age, probably we have to deal with only if she has a hirsutism, if she has a irregular cycles, if she has a obesity, acanthosis nigricans. Probably metformin is the only choice, or myonisitol could be a best choice for these patients. Normalize her insulin resistance. That is going to be a very long-term effects on her body. The second, if the patient is crossing 16 to 18 years of age, now this period of time, now regularity of the cycle is very important. Now, if this patient is coming with the androgen excess, that is hirsutism, FG score more than say 15 or 20, these patients definitely anti-androgen with ethinyl because from 18 years onwards, this can be given for over a period of say 4 years to 5 years at all the features of not having thromboembolism and these all things. And you can break that cycle, say give for 2 to 3 years, break the cycle, or you give only metformin in between, and like that you continue, but keep a track for a while. So all those medications is been in the PCO guideline. It has been written. Indian guidelines we have done. You can see Indian Fertility Society PCO guidelines for adolescents, and you follow those guidelines because they are with all evidences. Yes, Dr. Kaur.
Okay. So what would be the one important drug you would say to regularize a PCO? Like if it is a teen PCO is what the question is.
We need hyperandrogenemia to be coming down, and that's how we need anti-androgen with ethinyl would be the choice. So anti-androgen, you can cyproterone acetate or disoestral, or you can give, say, for example, you can have that Yasmin, or you can have that Yamini. All those will be there, or probably G8 or 9. These all medicine is the choice for them.
Thank you, ma'am. And the next question: how do you induce ovulation in a lean PCOS? Is there any different protocol you choose for a lean PCOS particularly?
The ovulation induction protocol, you mean, right?
Yes.
Yeah, I think, of course, as I mentioned that I will like to investigate her for insulin resistance. If she do not have insulin resistance, and if she do not have a reverse LH FSS ratio, then I won't give her oral contraceptive pills. I will directly start her ovulation induction. And only thing is that we have to keep it in mind that lean thin PCO patients are very prone in comparison with obesity. They are very prone for ovarian hyperstimulation. So you have to keep it in mind. Using a lower doses of gonadotropins is going to help. So we can start with letrozole 5 mg per day for second and third day. And I introduce gonadotropins in this group of patients with HMG 75 IU right from fourth day. And I will give it daily. Now, what is the difference between lean and obese in this category patients? So, especially the dose of gonadotropins. So, in obese PCO patient, that fourth day of HMG, I will like to start 150 instead of 75. But I'll be very careful in lean PCO patients. I will use only 75 IU. I won't start 150 right from fourth day because these group patients, they will always respond more to 150, and we don't want, OHSS is a lesser risk, but multiple pregnancy is the big problem with little excessive stimulation. And we don't want that in our controlled ovarian hyperstimulation IUI protocol.
I think the resistance is more with the obese PCOS compared to lean.
Yes.
The next question. Okay, ma'am.
Yeah. Yes.
Just a minute. Lean PCOS, don't go only for lean or obese patients. That's what Kavita is saying. Obese patients has a hyperstimulation and a lean patient doesn't have hyperstimulation. It all depends on how much AMH she has. What is her AMH values? If suppose here her AMH value is ranging between, say, more than 3.5, but it is ranging 8, 9. Whenever she has been going ahead of 6 or 8, you can think this patient who is a lean patient and probably she has a high AMH, start with a low dose. That is absolutely correct, Kundan. One more you can see on a sonography, polycystic ovarian morphology. Now looking at the morphology, if she has a thick stroma, those patients very unlikely to go for her hyperstimulation. But if she has a thin stroma and her more than 6 or 8 millimeter to begin with, probably those patients will go ahead with the hyperstimulation. But starting the low dose is always a correct way. Obese patients over a period of time, high androgen level will make her stroma thicker. And those patients are very high threshold. But if you go ahead with the threshold and just crossing that threshold, she may go into hyperstimulation. So look at the whole scenario and look at the AMH, polycystic ovarian morphology and the sonography, and then decide your dose of gonadotropins.
Yes, perfect, ma'am. Obese PCOS not reducing weight, how to proceed with fertility?
I think it's a big challenge when they don't reduce weight, because these kind of patients still persist having hyperandrogenemia. They do have a insulin resistance in their body significantly, and such kind of patients actually even they respond to your ovulation induction protocols very perfectly, but they do end up in luteinized unruptured follicle frequently. So I think it's a very important group of patients. But I think if they are not doing that, if they are not losing weight, but at least with insulin sensitizers, we will be able to achieve a clinical pregnancy rate. But I think the counseling is very important. We have to make them understand that obese patients, they are very, very prone for gestational diabetes. So we have to counsel them that we may achieve clinical pregnancy in them, but the prevention of risk factors like risk which is there during gestation as a diabetes, we are not able to provide. So we can in fact motivate them for weight reduction on these grounds, that it's not going to just help to achieve a pregnancy, it is going to reduce our journey. It is going to smoothen our journey, complicated journey of 9 months by preventing the diabetes. So the impact of kind of interventions also goes down, even if she has a gestational diabetes, if she reduces weight and achieve pregnancy. But I think if she cannot do it, I think best thing is to advise, if it is a morbidly obese patient, I think even doing a bariatric surgery in morbidly obese is a very important strategy, but cannot apply it for just overweight and obese patient up to BMI 30. We should not advise bariatric surgery for those group of patients, but still keep on counseling them the importance, and I think over the time period they will understand it. Sometimes landing up in luteinized unruptured follicle or giving no response to ovulation induction protocol sometimes then motivates them for going for weight reduction. So sometimes even doing the cycles and make them understand, see, this is the problem which is happening, and then they are ready to convince them. Yeah.
But still sometimes, as Kavita said, and the question is coming, some patient just doesn't budge. They will just not at all reduce their weight. They just don't reduce weight. What can we do for these patients? I think we have to straight start, because there is no option.
Yes.
What advice to them is that we do the stimulation, we take the embryos out, we freeze them, because we have to do the split cycle anyhow. So what we do, we will give them, now see, there are best embryos with us. Now you come down with your weight reduction. They get motivated. They know that now I'm going to be pregnant with this all, and they reduce their weight, and then 5% of the weight reduction makes lot of difference. Not only reduction, but even size inches, your loss in inches is going to make a lot of difference. That all motivates. So probably try like this. Start stimulation, make the embryos, and probably make her go ahead for the weight loss.
So if a couple, a woman who is like morbidly obese and married for 5 years, coming to you for fertility, do you give them a time for lifestyle modification or bariatric surgery? Will that be an option there?
My opinion, yes, because she's morbidly obese. So remember the metabolic abnormalities which are there associated with her. I think this decision is after the screening for metabolic abnormalities. Now all those metabolic abnormalities like abnormal lipid profile, having a abnormal GTT, having hyperandrogenemia features, or even having a low SSBG or free testosterone high. So once you have this kind of proof in your hand, then you can confidently tell them that yes, you do this now before even getting pregnancy. It's going to solve your many problems for the next 2 decades in her life. So I think the decision of bariatric surgery is not only on BMI, but also on the evidence of metabolic abnormality she has. I think on that, I think bariatric surgery advice should be or indication should be decided.
Thank you. The next I'm going to metformin. There's a lot of questions asked about metformin. So role of metformin in infertility patients for PCOS, they conceive, how long to continue, when to stop metformin. Can we combine metformin? And since you gave that combination study, many have asked whether we can combine metformin along with inositols. Is that being used?
I think honestly, we don't have a very clear evidence till today. There was not a single trial which is RCT and large size study, and for the clinical pregnancy as a parameter to observe. We don't have any single study where it was, tested that this combination was checked with only metformin or with placebo. We really don't have. Presently, both are effective drugs. That is what all the studies are showing, that they do improve. Metformin has got a better effective potency as an insulin sensitizers than myoinositol. Even those, we have those studies. But the problem with metformin is the GI side effects. I think that we have to keep it in mind. So those patients who just do not tolerate metformin, or those who have a severe GI side effects, I think we can shift them to myoinositol completely, because we saw certain studies clearly said that they are there is no significant difference in terms of action between these two drugs. So can be. In my practice, presently what I'm doing is I'm using both the combination, both the drugs together, and giving them for 60 days minimum prior to ovulation induction. I need Dr. Bharati Madam's opinion about it.
We did our own study with metformin with myoinositol. Three groups we did: metformin alone, myoinositol alone, and metformin with myoinositol. And we conducted 50-50 patients each arm, and we could find that metformin with myoinositol is the best combination. Problem only was the patient non-compliance for the metformin. That was the only issue. Otherwise, they were very good response. So probably combination is best, but still we have to wait for the evidence. Big evidence is very important. Randomized control trial. We are still
so combination means you give it before the start of, as a pre-treatment, before you start them for ovulation induction, or along with ovulation induction?
Before also and along with ovulation induction, both. Once they start, they continue till they become pregnant.
Can I comment, Kavita, on one question, one point here, that when we want to give this combination, because many of these PCO patients there are many papers in the last 3 years that they have shown that there's a very high ROS levels in the ovaries, especially in PCOS patients. And combining insulin sensitizers with some kind of antioxidants are definitely helping us. So even there was one paper who has studied combining vitamin D along with insulin sensitizers and using antioxidants like CoQ, melatonin. They have used it along with this combination, and they have shown a better pregnancy rate than just giving insulin sensitizers. So even there are few studies, but of course it's not a very kind of a red line evidence. We have a very high quality evidence we have, but there are good studies who have shown that combining insulin sensitizers with antioxidants for those 2 cycles are helping us to achieve more and more better pregnancy rate. So even there are some good studies regarding this.
Okay, I think the next question is similar. There's one question where they have asked, which is better, just myoinositol with metformin, or myoinositol with D-chiroinositol with vitamin D3 and ubiquinol, which that I think all the mixture of antioxidants, or just the combination.
I think we cannot really define patients who is going to benefit this. So at this moment, the current practice is that to give these combinations. So you give metformin along with myoinositol, and if you have a kind of 40:1 combination of myoinositol with DCI, but it has been recommended. See the papers which I quoted also in my presentation, they are demanding little higher dose in PCOS. They are saying that they have proven that 2 grams per day, twice a day, that goes to almost 4 grams per day, is what is they are recommending. Now in India, we have preparations where we have only 550 milligram, we are giving twice a day. So actually speaking, we are supplementing our PCO patient very limited doses of myoinositol. Probably that is why in our own studies, which we do it in routine basis in our own hospitals, probably we don't see sometimes myoinositol effective. But I think probably the dosage schedule is high. Supplementing myoinositol into 2 grams twice a day per day is something which probably will change the scenario. And as you, the question is about asking vitamin D combination and antioxidant. I already said I think that's a good combination to give. Probably it's empirical. but we don't know because we cannot categorize our patient who needs it and who doesn't need it. Madam, your opinion?
Dr. Kundan, you were absolutely right for myoinositol and Dicaro. It's a 40:1 ratio, but people have been now managing any 40:1. It's 500 and then 40 is into 1.2 like this. But actual dose, all those studies which has come from Italy, the basic and original studies of myoinositol with D-chiroinositol and infertility treatment or the combination is 4 grams. It's a and powder form. It's a sachet form. It's not a capsule. Capsule cannot be 4 gram ka capsule. You can't eat at all. It will be so big. It can't. So the sachet or the dispersible tablets is the only way of giving that combination or the myoinositol, because we are not giving the enough doses to our patients. The result is also haywire. The result is also not going to be very affirmative. So probably we need to know what we have been using and how much we are using the metformin and this myoinositol and D-chiro. Those you who are using a perfect combination, perfect doses, believe me, we are getting a very good result, and that's how we had actually done in those patients. It was 4 grams which was been given, but it is a sachet form. So sachet or a dispersible tablet, you can use anything, but capsule you cannot give that whole dose.
That is why whatever combination medicine available or preparations we have in India, I think what happens, they give adequate metformin, but we cannot give adequate myoinositol in this group of patients. So sometimes using that combination, give both the drugs but in a separate formulations, so that we can give good amount of drugs.
2 companies, very good companies, and they are giving a correct form, correct doses of the myoinositol and D-chiro. Probably those you should focus. I'm not going to name over here, because that's not a correct way of telling people, but you please look at the combination. There are Indian companies, there are 2 Indian companies which gives the perfect combination with perfect doses. So find it out, and that would be the real take home. Yes, Kavita.
Okay. The other question is, how long will you continue metformin for adolescent PCO, and also if the woman gets pregnant, how long to continue metformin? I think we've discussed, but that has been repeatedly asked, how long to continue.
Yes, I think it's a very important question for all of us, because I think 5 years back, we used to give metformin till 13 weeks of pregnancy, at least minimum, to the patient group to whom we have started metformin pre-pregnancy stage. But I think 2012, Cochrane review, when they said that it is not improving live birth rate, then we started thinking that once we achieve pregnancy, what is the need of giving metformin ahead in pregnancy, because it's not improving live birth rate, it's not reducing miscarriage rate. So I think the evidence is very clear that if the patient who has a significant insulin resistance, which is proven to you by GTT and clinical science, I recommend continuing insulin sensitizers, in fact, throughout pregnancy, because there is a very important study which is in 2019, where they have compared a patient who have, in one group they have given metformin all throughout, and in a second group of patients where no metformin or no insulin sensitizers was given, and birth weight as well as the incidence of gestational diabetes was significantly in favor of giving metformin throughout pregnancy. I think that was one only single paper which was, I don't remember the author name right now, but I think it's a very good paper which says that it is going to help you for this group of patients, because they are high risk for gestational diabetes. And that is why it is very, very important. Yes, madam.
I have a little different opinion. Say 12 weeks of gestation, you continue metformin or myoinositol, whatever you've been giving. From the trimester onwards, you have to follow the DIPSI test. So DIPSI test, if you follow OGCT, 75 grams of glucose, 2 hours single step test. If it is more than 140, please again add back your metformin or myoinositol and go on till 3rd trimester. Suppose 2nd trimester is fine, she doesn't have OGCT altered, or DIPSI test is been within normal limits, probably you go on the third trimester, again do the test and then probably go ahead. People have found that if you give a continuously metformin or myonisitol throughout the pregnancy, definitely she will not have a GDM. The incidences will be very, but those patients have been seen have a IUGR, intrauterine growth retardation, more on those patients. So probably on a borderline, if the patient is been not altered obesity, you be careful, no doubt about it, because you have to be PCO pregnancies. You must be careful, but do this way also, and that will be balancing your, the patient safety. Yes, Kavita.
I think what you said is right, ma'am, because I think we have to assess and then proceed rather than giving it continuously, I think. And the next question is, what is the best method to assess insulin resistance? I think the question is they want to know whether it is GTT or fasting glucose level or insulin level. I think they're asking that.
I think the best way is that intravenous insulin infusion test, but I think practically it's very difficult to do. So we don't follow it in India, at least.
So home IR.
I think
it's very
home IR index. So I think GTT is the best. And as I mentioned about certain clinical signs, I think if we combine GTT with clinical signs, then I think we will not miss insulin resistance patients. Madam, your opinion?
Absolutely right. Absolutely right. HOMA is very difficult. It is a research oriented. Your fasting insulin has to quickly go to the lab. You take out the blood and then go and assess it. It's just not possible. That's how your reports are not going to be so effective. It is good. It is for the research. You do your OGCT, very good, and clinical signs as the best way to judge the patient, and start with I think everybody has an insulin resistance. So you can just judge and can go ahead. So there is no need of fasting PP insulin to be measured at all.
Okay. Yes, I think we've discussed about adolescent PCO, then we discussed about insulin resistant, metformin, inositol. I think we'll move on to the ovulation induction. Which would be the best protocol for ovulation induction, starting from basic ovulation induction, whether CC or letrozole?
Yeah. I think letrozole is the best. I think if it is a very short duration of marriage and short duration of infertility, and she never have undergone any ovulation induction till now, so I think best to start with plain letrozole cycle also. We don't need to put them on the gonadotropins directly. So first, at least 2 or 3 cycles of letrozole is going to be sufficient to achieve a pregnancy. Now, what I follow in such group of patients, I put them for 2 cycles of letrozole induced cycle. At the end of 2 cycles, even she has developed single follicle induced cycle, but she has not been pregnant. In the 3rd cycle, I will add gonadotropins along with letrozole, so that we do a controlled ovarian hyperstimulation to improve their chances of pregnancy. And such more 2 cycles, we will get it done. In case if she doesn't conceive in at the end of these total 4 cycles, then we go for laparoscopy or to find out other reasons of failure, and then accordingly we further take the case.
Yeah, then that's right. You come across any time, because many of the people are asking this question only because our experience is also same. Not all patients of PCOS, when you put them on aromatase inhibitor, induce the ovulation. There are few number of patients, or few, that is a one subgroup of patient where letrozole still doesn't act. Have you seen that letrozole resistant patient? That is what
yes. That is where we start gonadotropin when there is resistance.
There are letrozole resistant patient also, where you will not find any amount of dose, maybe 5 milligram or 7.5 milligram will not be effective. Thing. Secondly, sometimes you go ahead, you get the good follicle, but your endometrium is still thin. It is not very good, and you start breakthrough bleeding in those patients. You don't know what to do. Because as we are going to use letrozole more and more, we will realize that there is a subgroup of patients where letrozole will not be the first choice, or it may not be a sole effective treatment for the patient. So what is your opinion?
Madam, I think this finding is definitely we will come across in 2 groups of patients. One group who's got a very high levels of LH, and where we have not used oral contraceptive pills in a prior cycles, where you have not downregulated pituitary, there the letrozole fails to elevate FSH beyond threshold, and because of which we don't get recruitment and no growth we follow. Now, that is what I always prefer, that any PCO patient whose LH is high, we always like to downregulate them. So we don't see, if we have done a downregulation, we don't see this kind of pictures. And also at the same time, this was seen into a group of patients where we use 2.5 milligram of letrozole. And that is where now the comparative trials between 2.5 to 5, in 5 milligram doses, we don't see much this kind of, because it is effective in taking the FSH beyond threshold. And I think that's why that 2.5 using, the use protocol has been gone down, basically. So, and it's what you say that we do come across it, putting them in gonadotropins is really helpful in the next cycle. We won't see that gonadotropin cycles.
So 5 correct, very optimum dose, as we have even clomiphene citrate, we knew few milligram to start with, and then we realized that overall 100 milligram works better, the pregnancy rate are better. So we now we straight put them on the 100 milligram. It is a 5 milligram now. There is one more aspect to the what Dr. Kund said about LH. He said, but the patient, PCO patients, one group of a PCO patient is a hypoestrogenic, and another group of patient is a hyperestrogenic. You know, whenever you see a patient is obese, usually will have a hyperestrogenic, like she will have a high estrogen levels. You know that unopposed estrogen comes and then goes on the endometrial lining. And the patient will have a thin patients will usually have a hypoestrogenic patient. Now, when the patient is a hypoestrogenic, letrozole drastically reduces your E2 levels. That has been proven. If you look at the clomiphene citrate and if you look at the aromatase inhibitor drastically reduces your E2 level, and because of the drastic reduction, your endometrium starts breaking down in between, and you have a thin endometrium, and probably she will not have a good endometrium. So that those patients probably will need your aromatase inhibitor with gonadotropins. So that will be the option for those patients. And a hyperestrogenic patient probably best for the letrozole, but optimum dose, that is a 5 milligram you can start. And maybe if she is not responding day 5 or day 7, you add a gonadotropin in those patients will be the best choice. So you will probably have a less failures with the aromatase inhibitor in this PCO patient. So PCO don't put them in one category, but it has got a different subgroups again.
I have one experience to share. In last 3 years, we found out in particular PCO patient, this is a selective patient group who showed that after giving letrozole along with gonadotropins, follicle got selected, but they got stagnated. They did not grow further beyond 10 or 12 millimeters. So what we realized that when we added letrozole 5 milligram on day 2 and day 3, and when we add this group of patient HMG 75 on 4th day, so daily we are giving HMG. So by 7th day, we see a recruitment of follicles 2 or 3, 10 or 12 millimeter. We continue the same dose of 75, but then after 2 or 3 days when we scan them, they don't grow. They have stopped growing. So I think it's not the problem that she is resistant to your drugs. Is the problem is that they need a more FSH dose in the early follicular phase. So same patient without any other intervention, we just added 150 HMG on 4th day in the next cycle after 2 days of same dose of letrozole, and they have responded beautifully. So it's like that wider FSH window, we keep it for them and they do. Sometimes it's not even drugs which are causing resistance. It's the problem that those patients needs a more FSH dose or more HMG dose for their continuation of recruitment and growth. And that's what is my observation.
Patient, it was a LH ceiling effect. You know, probably the LH ceiling, she needed more FSH. Recruitment was necessary more. Little bit of recruitment happened, but dominance was not happening because the LH was suppressing that. And probably that LH, when you took it out, FSH you added, that started booming up. Probably that the. So probably looks like that as with his, there is no true or aromatase inhibitor resistance, but we may have to add the gonadotropins according to her hormonal profile.
Yes.
Okay. So, is there what kind of gonadotropin you use for PCOS? Is it only FSH, or sometimes you combine FSH and LH, or is it HMG?
I think it's a good question, and I think answer has been already solved for this question by this time after Megaset HR trials and those couple of trials, that none of the gonadotropins is superior than each other, and especially if it is for IUI, where we want 2 or 3 dominant follicles. I think HMG has been proven better because the OHSS rates are lesser with HMG than recombinant FSH. Sometimes patients do respond to recombinant FSH very drastically and have more follicles, like 5 or 6 dominant follicles. So I think severe OHSS is rare with recombinant FSH with small doses, but even mild OHSS is more with recombinant FSH. So I think HMG is safer. Even the meta-analysis for PCO patients. Yes, madam.
Both are equally in the, see, all the randomized control trial meta-analysis, everybody has been saying that FSH, HMG or FSH is fine, both okay. Probably it is to do with FSH or LH receptor polymorphism. Every patient has been different, and probably sometimes you get a very good result, sometimes you don't get the result. It is to do with the FSH or LH receptor polymorphism. I think we should leave this here because it's a big debate altogether. But FHMG or FSH overall, if you see, doesn't make any difference. So you can start anything. HMG thoda sa crossover because it gives LH, and LH always gives a better intravariant environment as such. Probably that's the way. Yes, Kavita.
Okay. Do we have to down-regulate before we start to induce PCOS?
I think we discussed about it by giving oral contraceptive pills. It is an effective strategy. There are many randomized control trials which have proven that OC pills, down-regulation with OC pills rather than GnRH agonist. I won't say that you down-regulate with GnRH agonist. It's too long process, too many injections. Also, it will be frustrating for the patient. I think OC pills should be a good drug of choice.
But OC pill also has a lesser pregnancy rate with down-regulation.
I think the OC pills. Yes, madam.
Not say OC pills, but we should say optimization rather than saying down regulation. If we say optimization, that would be a right choice, because we don't give GnRH agonists for down regulation. Even OC pills also we do not give as a down regulation. We give anti-androgens to them, and then we reduce their androgen environment and the levels. So we don't give OC pills like just OC pills, because that is proved that it doesn't give a good pregnancy rate if you suppress with the OC pills. So don't take that OC pills in the mind. It is anti-androgens. We don't want her androgenic environment to be a very active. We want it to be specific. Androgenic environment will not give us a good follicular growth. So optimization would be the best choice or best word to be used rather than down regulation. So optimize your patient by different ways.
Okay. Yes. The next question is about PCO drilling. Is it mandatory, or how do you choose a patient for PCO drilling?
I think the purpose of ovarian drilling is to correct her ovarian morphology, probably which is more androgen producing stroma. I think I feel that should be a second line drug. Second line method of ovulation induction. I think we can achieve with good drugs we have now, ovulation induction drugs. I think we can achieve pregnancy with these kind of methods rather than doing any surgical approach. Because see, the message has to be very clear that once you put a laparoscopy at the first instance, you see a polycystic ovarian syndrome. See, if you do a drilling at that stage only, I won't recommend you that, okay? Because that's not a first line drug. The question is that suppose a patient who has already undergone couple of IUI cycles, now every time she hyperstimulated, okay? Now, if for some other reason I have put a laparoscopy, that is for endometriosis and for my intention of doing IVF in her future cycle, and I know that she has already hyperstimulated in previous 2 cycles of IUI, probably I might think, but not even 100%, but I might think doing drilling just to prevent that hyperstimulation risk which can happen in IVF. Okay, but still I'll be very, my mind will not say that to do a drilling. Believe me, last 3 or 5 years, I've never done a drilling in my PCO patient as a first line, never done as a second line also. We never required a drilling. So I have kept it drilling in my practice for a limited role. For a patient who does come, very poor patient who is, we are sure that she's far from the village, she's poor, she's not going to afford all these things. You want to drill her, leave her alone. After drilling, at the end of 15 months, the cumulative pregnancy rate same what you would have achieved in 6 months of ovulation induction cycle, and there are studies to support it. So sometimes we have to drill the ovaries and leave the patient for 15 months. At the end of 15 months, there are chances of pregnancy are better. So it is for a little longer time. I mean, you cannot assure a pregnancy in a shortest time. But for those patient group only, I might think of doing a drilling because they are not going to come back and they are not going to do any treatment. So that's
okay. What is the best protocol for IVF? I think ma'am is saying.
Ovarian drilling.
Yeah.
Ovarian drilling, if at all you decide to be done for any patient, suppose basically all IVF specialists now, the drilling has been almost not there. I must not have done for almost last 6-7 years now. Drilling is not done. But if at all you have to do the drilling, you have to look at her AMH. If her AMH, categorize her AMH. Otherwise, don't do. Even if she is not responding also, even if poor, if she is not going to come, whatever it may be a reason, if her AMH between 3.5 to 6, don't drill this ovary at all. Otherwise, she is going to go into premature ovarian insufficiency over a period of time. So don't drill that ovary at all. If it is between, say, after more than 10 nanogram per ml, 10 and onwards, don't drill that ovary at all, because that is not going to be effective at all, because she has a very high androgen. Just drilling 3, 4, 5 punctures, androgen level is not going to come down, and it is of no effect at all. Probably no hyperstimulation or low risk of hyperstimulation could be there, but there is no point. 6 to 8, AMH between 6 to 8 is the best category or the subgroup of a PCO patient where your ovarian drilling is going to be effective. Otherwise, I don't think below 6 and more than 10, no role of ovarian drilling at all. Yes,
okay.
Kavita.
I think we are way beyond our time. I just have last 3 questions. One is, do we give ethinyl estradiol for thin endometrium? Is there a role for ethinyl estradiol when during ovulation induction you see a thin endometrium? Do we have to add it?
Ethinyl estradiol.
Yeah.
Estradiol valerate, sorry.
Estradiol valerate. Okay.
Valerate.
That means supplementing estrogen during follicular phase. That's the question, right?
Yes.
No, I don't think so, because we have to remember that endometrium is under control of estrogen for the development, and one single follicle, which is a good quality follicle, will produce estrogen beyond 125 nanogram. I think it's very important that with that also sufficient endometrium can be achieved. Adding that 2 milligram, 4 milligram or maximum 6 milligram per day of estradiol valerate is not going to significantly change. Now, I think I know why people are saying this, because sometimes we do see that a defective follicle is selected, a single follicle, the estrogen levels are very low, 60, 70, 80, the endometrium is thin. Now, if you add estradiol valerate at this stage, after 2 days or 3 days, you see a good growth of endometrium. But still, the pregnancy is not going to be achieved because your follicle is defective, which is not going to give you the better embryo or better egg. So ultimately, pregnancy we don't achieve. Okay, so I don't think so. And even to back up this statement, I think we have a lot of studies where giving estradiol during follicular phase has been studied, and I think clearly there is no role of estrogen supplementation in follicular phase.
Okay. What is the best protocol for stimulation for IVF? PCO stimulation for IVF?
I think a madam will also agree antagonist will be the best for PCOS patient. And I think I always prefer, because they are hyper responders, better to do a frozen embryo transfer cycle than a fresh cycle. So
100% sure.
yeah, so use gonadotropins, use a fixed GnRH antagonist protocol, give GnRH agonist as a trigger, recruit the oocytes, freeze the embryo, and later on, either because they are PCOS unovulatory patients, I prefer down-regulated HRT cycle for these group of patients. But you can do without down-regulation HRT cycle also in this group of patients. There won't be any change in pregnancy. But I will prefer doing down-regulated HRT cycle. Madam?
Not a fixed antagonist protocol, flexible I will be using, because 12 to 14 millimeter follicle has to go ahead, and that time you add the antagonist would be better. Otherwise, gonadotropin, perfect antagonist, freeze all, do not take any chance at all. Don't ever think that she is going to be hyperstimulated. Everything is fine. She can have a secondary hyperstimulation when she becomes pregnant. So probably we don't want her ovaries has to be quietened. They get a very good pregnancy rate, excellent pregnancy rate with FET cycles. FET cycle, no need to down regulate also. As such also she is an unovulatory patient. So there is no down regulation needed. You can go with the estrogen and then the progesterone, and that is going to be sufficient. So antagonist protocol is the best protocol for IVF.
And how do you manage hyperstimulation if in case you see a patient with hyperstimulation?
IUI are you talking about?
PCOS hyperstimulation is always predict, prevent, and then manage. Prediction is very, very important. Which patients are going to 3.5 nanogram per ml AMH? You have to think, make it red mark on that paper. So she is going to go into hyperstimulation. Suppose by chance you didn't see, then when you are stimulating the patient, day 5, how many follicles are there? What is her E2 level? In case you miss there, day of your pickup, you stay, day of your trigger, do not give HCG at all, write it down on PCOS patient, on the paper, in the red, no HCG for trigger. So you will, half your problem will solve there. GnRH agonist will be the only trigger for her. Then in there also, and you go ahead and you aspirate the follicles. If there are more than 25 or 30 follicles, give GnRH antagonist 1, 2, 3 times. Dopamine agonist 1, 2, 3, 7 days continuously. Look at her follicles. She has to reduce her ovaries. Don't transfer the embryos at all. Still, sometimes if the patient goes ahead, mild, moderate, and severe, categorize them. Look at her PCV, simple marker. PCV, if it is more than 35, she is going to go ahead into a moderate hyperstimulation. 38 onward, severe hyperstimulation. See the ascites, see the fluid around. You must remember your main culprit is your vascular endothelial growth factor. If it releases, it is going to have the capillary permeability. Once the capillary permeability will be there, your all inside plasma is going to go out with the permeability, and your free fluid is going to start. So stop there. Calcium channel blocking has to be over there. And if you start managing her, mild to moderate patients can be at OPD level managed, but when it crosses moderate and goes into ascites and the this pleural effusion, patient has to be admitted. And very aggressive treatment has to be fluid restriction. You have to give a starch, then you have to monitor her all the blood parameters, and accordingly you start managing ascites tapping, pleural tapping, all those things. But probably we are not facing nowadays this. I have hardly seen any patient last 35 years. Now last 10-15 years we are not having any hyperstimulation, because we all know that this is going to happen. This is a iatrogenic complications.
So after freeze-all, I don't think we'll be seeing any hyperstimulation at all.
Yes.
An antagonist cycle, agonist trigger.
So I think it was a wonderful discussion. I think Kundan and ma'am, I think you've given all the possible answers, and there are few more questions there, but I think it's all repetitive questions, so I'm not handling that right now. I think thank you so much for the wonderful knowledge you've shared.
Thank you, Kavita, for I think it's a very important job because our viewers who are listening to all of the presentations, but sometimes there's the presentation doesn't cover all aspects of their questions, and sometimes this discussion plays a very important role than the presentation. And I think I thank you to you, Kavita, for conducting and attending those questions and getting very important points for our viewers. And Madam Dr. Bharti, I think huge experience in your life. I think it contributes a lot when we also speak sometimes in the sessions. I think your experience counts and help us to follow many things in our practice. So I think I'm hope that our viewers are going to have a lot of benefit from this. And I think Session, Mr. Session, if you can take over the further proceedings. Are you there?
Yes, sir.
Yeah.
So first of all, I would like to say a fantastic talk by Dr. Kundan and a very riveting panel session between the three of you. And we have an audience of excess of 800 on a Saturday evening. This shows that people still want to know more. And I'm sure that with the amount of questions that are coming in, this would continue for at least an hour or so. And with the vast vault of knowledge that you guys have, this will definitely go ahead. But all good things have to come to an end. So I would first of all like to thank Sanofi as the sponsor for this program. And last but not least, the academic wing of Foxy. We would definitely like to thank ICOG for granting their one ICOG point for the attendees for this program. And we definitely look forward to seeing all the audience again on the next series. So thank you very much. Thank you, Dr. Kundan. Thank you, Dr. Bharti. Thank you, Dr. Kavita. Thank you very much.
Thank you.
Bye.
Thanks, Session.
Have a great evening.
Thank you.